Hello, I'm Niddhi Kuumaar and welcome to the show. Today we make an honest endeavor to develop the scientific temper of our society. We talk about thalassemia today, which is a chronic blood disorder which leads to anemia, and patients also require blood transfusions every 2 to 3 weeks to survive. Thalassemia is an inherited blood disorder in which the body makes an abnormal form of hemoglobin. Hemoglobin is the protein molecule in the red blood cells that carries oxygen. The disorder results in excessive destruction of red blood cells, which leads to anemia. Anemia, as we all know, is a condition in which your body does not have enough normal, healthy red blood cells. To talk more on this disease, we have with us two very eminent people who have been creating milestones in its treatment. I'd like to welcome today Dr. Vikas Dua, a Paediatric Hemato Oncologist and bone marrow transplant specialist of the generation. He and his team have done over 200 plus pediatric transplants. He is also known for his excellent outcome in stem cell transplant, especially in pediatric haploidentical transplants, and he has done some of the very rare transplants which nobody else has done in India. We are also joined by another very eminent doctor, Dr. Mansi Sachdev, MD Pediatrics, consultant in Department of Paediatric Hematology and BMT, Fortis Memorial Research Institute, Gurugram, fellowship in Paediatric Hemato Oncology and BMT from USA. I'd like to welcome both of you to the program
Thank
today.
you very much.
And the subject itself is so very interesting, and it is such a rare disease. So tell us about thalassemia, Dr. Vikas.
So thalassemia is a genetic disorder actually. So in thalassemia what happens is your body is not able to make sufficient red cells. So once a baby is born, it's a genetic disorder. The parents are actually carriers. That means the parents are carrying the genes inside them which they are also not aware of. And when two carriers or two minors get married, after 6 months of delivery, the baby is anemic. The hemoglobin starts falling. The baby requires a blood transfusion. So that's how a patient of thalassemia present to us in a routine practice. And then once we diagnose that patient with thalassemia, the patient would require monthly blood transfusion, or what you said, 3 weekly blood transfusion for the rest of the life if we don't do a permanent cure for these unlucky kids.
But it's so sad, and very less awareness has been there even in India about this disease. So Dr. Sachdev, can you tell me where all this disease is prevalent, and why is it mostly in the Asian countries, this belt?
Sure. So thalassemia usually occurs among people of Italian, Greek, Middle Eastern, Southeast Asian and African descent. And if you talk about India, in the Indian subcontinent, we have certain belts where thalassemia is more prevalent, like Punjabis, Sindhis, Gujaratis, Parsis and Bengalis, to name a few. Now, since it's a genetic disease, that's why it's just prevalent in those areas. So, it's very difficult to say why those areas, but it's a genetic mutation that just happened.
Correct.
What do you think the reason could be because of this being prevalent?
Probably in these societies, in these communities, some mutation has happened in the past, and that's why these patients have got.
So Doctor, about Sri Lanka also, there's a lot of it happening there. Why so?
So all the neighboring countries, I should say, not just Sri Lanka, I would say Pakistan, Nepal, Bangladesh, Bhutan, Burma. So these are the countries where thalassemics are very many.
Can you throw some light, Dr. Mansi, on who are the carriers of thalassemia?
Let's just talk about what does a carrier state mean. So we know that a child actually gets genes, half of the genes from mother and half of the genes from father. So, sometimes these carriers, so say if mother has abnormal hemoglobin producing genes, so if it's a thalassemia major, she will come into light because she will need blood transfusion. But when you are a carrier, you have no symptoms at all. You actually lead a very normal, healthy life. You never get medical attention because you live your normal life. So when a thalassemia carrier marries another thalassemia carrier, then they have a chance that they can produce a thalassemia major child. But if a thalassemia carrier marries a normal, healthy adult who doesn't have thalassemia, then there is a chance that they're not going to have thalassemia major kids. They either have normal kids or they will have thalassemia carrier kids, who again will not show any signs or symptoms of thalassemia at all, and they will lead a normal adult life. So that's why it just goes missed for so long. But what I want to highlight here, I'm very happy that you've asked this question, is that since these patients don't get the medical attention, it is very, very important, especially for women who are childbearing age or who are planning to get pregnant, to get simple tests, blood tests done to find out if they have thalassemia minor or not, because that will tell us if they are going to have a kid who can have thalassemia major or not.
Absolutely, which leads me to my next question to you, Dr. Vikas. She just mentioned major and minor. So could you please tell us the difference between a thalassemia minor and a thalassemia major?
Yeah, sure. So thalassemia minor, you can use a word minor, you can use a word trait, you can use a word carriers. So minor, carrier or trait is one and the same thing. That means these people are normal. They don't require blood transfusions. They are not anemic. They are normal like us. But if you do a blood test, a thalassemia screening test on them, you will come to know whether they have got that mutation, that gene inside them or not. That's what Dr. Mansi has just highlighted, that if two carriers or two minors get married, there is a 25% probability that may produce a thalassemia major baby, which is a burden to the family and to the society. So that's why a screening is important before marriage or before conception of the mother and the father to know what is their thalassemia status. So that is about minor. But when we say major, major is actually a problem. So that means two parents who have got genes of thalassemia inside them got married, and as there is a 25% chance of producing a thalassemia major baby. So that doesn't mean that if you have one baby who is normal, the next 3 pregnancies are going to be all right. So you are at risk in each and every pregnancy. There is a 25% risk in each and every pregnancy, and once that baby is born, from 6 months of age, that baby would require blood transfusion, would have a big liver, big spleen, and would be a problem for the family and for the society and for himself also.
And would also be chronically fatigued most of the time.
Fatigued,
yes.
Undoubtedly, because these patients are going to be anemic. So once your hemoglobin goes down, your energy levels are down, and that's why you're fatigued.
We're going in for a short break. When we come back, we'll look at early detection in the field of thalassemia and the importance of its treatment. Welcome back, and we're talking about the very rare disease, thalassemia. Just before we went for the break, doctor, she spoke about chronic fatigue and how these children can be very stressed out, even if they're minors. But I'd like to add to what she said and ask you another question, which is that if a couple has one child who has thalassemia, is it necessary that the other offspring or the second child will also have the same disease?
No. So in each and every pregnancy, if two thalassemia carriers get married, in each and every pregnancy there is a 25% chance that they may produce a thalassemia major baby. So that risk is there in each and every pregnancy, but that doesn't mean that in all the pregnancies you'll produce a thalassemia major baby. That's why nowadays, if somebody has a thalassemia major baby in the family, then if they're planning for a second baby and the mother is pregnant, then inside the womb you can get it checked. So between 10 to 12 weeks of pregnancy, I think Dr. Mansi is going to talk on that later, that inside the womb you can come to know whether the baby, who is the fetus, is actually suffering from thalassemia major or not.
And how does one diagnose this? What kind of blood tests are needed, Dr. Mansi?
So to diagnose thalassemia, it's just a simple blood test. That's why we urge the society, people, that
and all our viewers,
and all, yeah, of course, that if you have a family history of somebody needing blood transfusion repeatedly, don't wait. Just come. It's a simple blood test. It's called complete blood count, where we are going to look at 3 or 4 indices.
Dr. Vikas, you've been doing so many of these bone marrow transplants. My question to you is, are they successful? What happens in a bone marrow transplant? And if the person who is giving this transplant, is he at a risk or is she at a risk?
Definitely, I would like to answer that, but before answering that, I would like to add what Dr. Mansi has said when we talk about diagnosis, because diagnosis is very important. Prevention is always better than cure. So the test which is called HPLC or HP electrophoresis, that can be done from any referral lab at a very nominal cost of 650 rupees. So in 650 rupees, you can come to know your thalassemia status. So nowadays, no need to check horoscopes. Please check your HPLC status. That's one thing. And the second thing is that even if we talk about people like Amitabh Bachchan, so I don't know whether people sitting over there, they know that Amitabh Bachchan himself is a thalassemia carrier. So thalassemia carrier doesn't mean that he is a major, he is requiring blood transfusion. He has a gene inside him that he can produce a thalassemia major baby, but fortunately Jaya Bachchan is not. So father, Abhishek Bachchan's father is a minor and mother is normal, that's why the kids are okay. So if two carriers get married, then there is a risk. Okay, coming to the treatment. So as we speak today, the only permanent cure for thalassemia major is a bone marrow transplant or stem cell transplant. So the correct term nowadays is stem cell transplant rather than bone marrow transplant. So previously people used to think that we just collect the stem cells from the bone marrow, that's why we call it bone marrow transplant. No, so that's not the correct thing. So we are not going to break the bones of the donors or of the patient to do a bone marrow transplant. So the donor is it's absolutely safe for the donor. There is no risk. But when we talk about the patient, we are changing the immune system. The patient has a defective gene inside him. His red cells are defective. That's why you have to get rid of that defective red cell you have to get rid of that and you have to replace that with a healthy red cells. So you have to give some sort of chemotherapy. You have to ablate the bone marrow of this unlucky kid and replace that with normal red cells. So that's what a bone marrow transplant is.
How beautifully said. So there is a lot of hope for such patients.
Correct.
Dr. Mansi, now I want to ask you, what are the factors that increase the risk of thalassemia? And,
Sure. Can I add just a little bit what Dr. Vikas has said? You had asked about the donor. So donor has absolutely no risk. Nowadays we are even doing peripheral blood stem cell collection, where we just put like a cannula or a simple line and we collect, like you give blood transfusion. That's how we collect stem cells. So it's that simple, and there is no risk to the donor. So please, I would also urge that not everybody who has thalassemia or any other disease which is treatable or curable by bone marrow transplant, please register yourself, because you could be a donor. You could become a donor for people who have thalassemia, who have high risk leukemias and things like that, and you can actually save a life. So just go and register, and
it's a very, very, very wonderful and important message, this, that all of us should register so that we perhaps could save lives.
Exactly. So the viewers who are sitting over there, so you all need to know that the best donor is a brother or a sister. A healthy brother or sister is the best donor, but there is a 25 to 30% chance that the brother or sister is on a complete match on HLA with the patient. So there is a 25 to 30% chance that a patient who is requiring stem cells would have a match from brother or sister. So what about the rest 60-65% people? We need registries. We need people sitting out there to donate stem cells who can be a ray of hope for these unlucky kids.
Absolutely. Dr. Vikas, now I want to ask you about the possible complications, if any, in the treatment. Supposing a child is coming to you for blood transfusions, what all can happen to the child? What are the things they should be able to perhaps understand so that the treatment is done at a proper level?
Exactly. So transfusion, honestly speaking, is never safe. Each bag of blood contains 126 milligram of elemental iron. So these are iron. I'm talking about iron. So every time they are going for a transfusion, they are getting 126 milligram of iron from that blood unit. And these kids would be requiring monthly blood transfusions. So after 10 transfusions, we check their iron status. After 10 transfusions, if their body iron stores have gone up, we have to put them on some medicines called iron chelators to get rid of this iron, because this iron would get deposited in the heart, in the liver, in your endocrine glands, and can cause issues.
So, word of caution there, very well taken for our viewers. And on this note, we are going in for a short break. Stay with us. When we come back, we'll look at challenges in the field of thalassemia and the importance of blood tests. Welcome back, and we are talking about the importance of blood tests, diagnosis and treatment of thalassemia. Dr. Vikas, before the break, we spoke about various kinds of blood tests and bone marrow transplant. Thalassemia is inherited. So what other precautions can be taken by the patient other than the blood test to find out whether he or she are carriers?
If somebody in your family is anemic, and if somebody in your family is getting blood transfusion, a repeated blood transfusion, that means that that's a more important thing for you to check your status.
That is a signal.
Exact. That's a signal that you should check your status. And the other thing is that the minor person, the trait or a carrier, is otherwise asymptomatic. So you cannot come to know by seeing the face of a person whether that person is carrier or not. So you have to do the test called HPLC to come to know the status.
And supposing a patient is ridden with this so-called disease, then what is the diet that would you prescribe?
Yeah, so that's a very important thing. I just now mentioned that with each unit of blood you get 126 milligram of elemental iron. So you have to take a diet which has got low iron content. You're already getting iron from the blood. If you keep on eating things which has got a lot of iron like jaggery, apple, then this will also get absorbed from the intestine and will increase your iron levels in the body. So what we suggest these families is that to avoid iron rich food, or if the child has eaten an iron rich food, then to take tea or coffee after that, because tannin decreases the absorption of iron from the intestine. So that's an important thing which all the thalassemia families needs to know. Avoid iron rich foods, but if somebody is taking iron rich foods, to take tea after that meal.
And what happens in case of a person who is pregnant, Dr. Mansi?
So again,
if we talk about diet.
Right. So in that case, you have to talk to your gynecologist. You have to involve a hematologist as well, because in itself, when you are pregnant, you need to take more iron. But during pregnancy, you might be getting the transfusion, so you might not need that iron.
And you also cannot psych the patient that you're going to have this problem. That is also very important. So how do you deal with such patients who are carriers?
Right. Right. So you have to tell them that this is what it is.
Difficult.
Yes, and this is what it is. You have to do what you have to do, and you have to get your partner checked, because it's a simple blood test, because it's very important. Right now they might think in their frame of mind, they might be in the frame of, wow, we have a child and we don't want to get any testing done. But down the line, once they get to know, and once the child is born, that's when it will hit them.
So a lot of people, a lot of families come to us with a baby who is 4 months, 6 months old and is anemic, and we diagnose. For the first time, we tell them that the baby is thalassemia major, and they were not aware of their thalassemia status.
They don't even perhaps have heard of this disease.
Exactly. There are many of them who don't have even heard of this problem. So that's why awareness in the society, even in the doctors, I would say. We are hematologists. We deal with thalassemia left and right, but there are primary physicians, there are healthcare providers, there are physicians, there are gynecologists who don't know that HPLC test, a test is available which can be done before marriage or before conception, which can save the birth of a thalassemia major baby.
Absolutely. What is the cost of the treatment, doctor? This is very important, because a bone marrow transplant cannot be afforded by many, and hence they go in for blood transfusions.
Exactly.
So is there a way out? Is there some kind of agency that supports them? Perhaps the government also. What about people from the villages? What about people from panchayats? What about people from districts? There are 149 districts in India who don't know anything about thalassemia.
Yeah, that's why we always say prevention is better than cure. In 650 rupees you can come to know your thalassemia status. So to know your thalassemia status, the cost is 650 rupees, but for a treatment you have to pay 15 to 20 lakh rupees.
Here again I'd like to interrupt you. You said 650 rupees, fine, well taken, but is this test available at the district level? No. Is the treatment available at the district level? No. You have to come to metros like perhaps Kolkata or Delhi.
Exactly. So town B cities, town C cities, they don't have transplant centers, but there are labs. It's an easy test. There are labs which can do this test in that city and which can tell you your thalassemia status. So 10 to 15 lakh rupees or 15 to 20 lakh rupees, when we say, is exclusive of any unseen complications or ICU visits. If somebody gets a complication, then the cost may go up. And that, I'm not saying that will happen in a private hospital. If you go to a government hospital, you have to pay because you would be treated like a private patient and you have to pay and bear all the expenses. Majority of the time, people have to pay from their own pocket. The reason is that it's a genetic disorder, so it is not covered under insurance. But there are ways, there are NGOs, there are government organizations who may help you with some financial support in getting a transplant.
And it is very, very important to get to the root of it, and for curing this problem completely, and for the patient of thalassemia to be able to live a long and healthy life, it is important that a bone transplant needs to be done.
Exactly.
So Dr. Mansi, I'm trying to ask you now, from gathering all this information, is that what kind of research is going on in this field? What kind of international norms can we perhaps follow to bring in more awareness for the viewers as well as better treatment for them?
Right. So at this point, I would like to add to the bone marrow transplant treatment that, as Dr. Vikas said, that we have siblings. When siblings are available, they are the best match for a thalassemia patient. When we don't have siblings, we have what is called a match unrelated transplant, meaning that you're getting the stem cells from an unrelated donor. Now, the third type of transplant is a haploidentical transplant, which is half-match transplant, so from mother or father. So like I told you before, that half of the genes are from mother and half are from father. So when you do the HLA typing, which is a test to see the genetic makeup of the child, definitely half of it will be from the mother and half of it will be from the father. Haploidentical transplant is half-match transplant. So that means all children who have thalassemia or high-risk leukemia or whatever disease they have, which is curable by transplant, they always have a donor available at home. So that is something that is upcoming, and we have done a lot of haploidentical transplants in thalassemia with good outcomes. Now there's a new research that is going on, which is called gene therapy, which is still in the research side. It's still not come to the bedside. It's still bench work, but we are hopeful that in the next maybe 5 or 10 years, this is going to come up.
Doctor, can you throw some light about the patients that you have been treating who have been admitted? After all, they're only children. Are they happy once they know that the treatment is going on, or do they have sad faces? And what do you do in your hospitals to kind of cheer them? Because they must be wondering that there is something wrong with them. That is why they are hospitalized for long periods for bone marrow transplants.
So being as pediatric hematologist, oncologist, and bone marrow transplant physicians, we deal with small kids. We deal with kids from day 1 of life to 18 years of age. So our patients are not adults. So we cannot make these small kids understand that we are going to change the immune system. So it's actually very difficult. So we need the help of many people, definitely the nurses, the parents, the psychologists. So these all come into play at that point of time when we are actually admitting these patients, because they are going to stay for a long time. So when we admit a patient of thalassemia or any other patient for a transplant, they have to stay in the hospital for 4 to 6 weeks. 4 to 6 weeks being in a hospital in a single room, it's not easy, and definitely for a small kid. So we do face challenges, but it's worthwhile, because once a transplant is done, once 4 to 6 weeks have passed, once the patient is out of the hospital, he lives a normal life like us. So from a thalassemia state, he has come to a normal state. No more blood transfusion, no more poking, no more getting of iron chelators, and living a normal life. So it's worth, I would say, worth doing a transplant for these kids, because once a transplant has been done, 1 year goes away, the patients attend the school, can go to all the public places,
and then they can go to school and back to everything.
Correct.
So the message essentially is that to all our viewers, that they should all be a part of the donor system and try and save lives. With this, I'd like to thank you both for joining us today for this very, very pragmatic and interesting conversation, which was all about thalassemia. Thank you.
Thank you.
And to all our viewers, People with thalassemia are advised to attend all their regular appointments, maintain contact with friends and support networks, to keep a positive attitude and follow a healthy diet to maintain good health, get a suitable amount of exercise. We'll bring you more on some new scientific initiatives soon. Many thanks for watching. Namaskar.